morning, everyone. If you went to the opening lecture, I lost my voice in that talk, so I apologize in advance if this happens again. I may need to fill up my water. But this session is going to be on muscle disease in systemic sclerosis. So just listed here, the objectives, we're going to review symptoms and clinical presentation of muscle disease in patients with scleroderma, review, test to diagnose and monitor muscle disease, and review treatment modalities for muscle disease in scleroderma patients. So again, listed here is an overview of what I'll be talking about. I'll be covering classification, epidemiology or frequency of muscle disease, risk factors, symptoms, evaluation, treatment, and prognosis. So first of all, the classification of muscle disease in systemic sclerosis. So it's important to realize that all muscle disease in scleroderma patients isn't necessarily related to the scleroderma. So there are non-scleroderma related muscle disease, and then the other three are muscle disease that is thought to be related to scleroderma. And that can be either inflammatory, where there's a lot of inflammatory cells in the muscles. It can be non-inflammatory, mostly scar tissue, or it can be what's called immune-mediated necrotizing myopathy. And in these patients, there's a lot of dead tissue. Necrotizing means dead, and so there's a lot of dead muscle tissue, and this is thought to be related to an autoimmune process. So first, want to mention again that all causes of muscle disease in scleroderma patients is not necessarily related to the underlying scleroderma. So there are various disorders that can lead to muscle weakness and muscle disease, including thyroid disease, one of the major causes, Cushing's syndrome, having electrolyte problems, your potassium, phosphate, calcium, all of those should be checked to make sure they're normal before assuming that you have muscle disease relating to scleroderma. Metabolic myopathies are less frequent in scleroderma patients. These are usually inborn problems with metabolism. But drugs are a huge cause of muscle disease in patients with scleroderma and other non-scleroderma patients. So some of the culprits include illicit drugs like cocaine and heroin. You should always ask your patients whether they use illicit drugs. But more common things are alcohol. Alcohol can lead to muscle disease if taken too much. Corticosteroids, drugs that we use all the time to treat autoimmune diseases, can lead to muscle disease. And then other drugs that scleroderma patients are often taking, things like anti-malarial drugs like hydroxychloroquine or Plaquenil. Colchicine is a drug that we sometimes use in patients with gout, also can lead to muscle disease. And then HMG-CoA reductase inhibitors. These are medications otherwise known as statins, frequently used by all patients for the treatment of high cholesterol. And then finally, penicillamine is a medication that probably not as many scleroderma patients are on currently, but used to be a very frequent treatment for scleroderma patients to try and improve their skin tightening, and now is also known to be associated with developing muscle disease. Infections can be a big cause of muscle disease. So viruses, bacteria, fungi, and parasites can all lead to muscle disease. And then finally, rhabdomyolysis is basically related to injury often. So trauma, seizures can lead to breakdown of muscle. So all of these things have to be excluded before you think about inflammatory causes of muscle disease that might be related to scleroderma or another autoimmune disease. So as I mentioned, for scleroderma-related muscle disease, you can have inflammatory forms or you can have non-inflammatory forms. So there are diseases that we treat as rheumatologists called inflammatory myopathies. These are including polymyositis and dermatomyositis. And basically, these are autoimmune diseases that involve inflammation in the muscles. So patients with scleroderma can develop inflammatory forms of muscle disease that are very similar to patients with polymyositis. They can also have overlap features with dermatomyositis. So what's the difference between polymyositis and dermatomyositis? Dermatomyositis patients have characteristic skin rashes that they can develop as well. And so in these inflammatory forms of muscle disease, basically you look for muscle inflammation on muscle biopsy. And you can see that they have muscle inflammation even in their bloodstream by elevation of tests called muscle enzymes. Again, there's inflammatory cells on the muscle biopsy, and most of the time these patients will do well if you give them immunosuppressive therapy. In contrast, the non-inflammatory form of scleroderma muscle disease is more related to scar tissue or fibrosis in the muscles. There can also be necrosis or dead tissue. And really there's not much inflammation. So these patients don't really have high elevation of these muscle enzymes in their bloodstream. And there's dead tissue or necrosis and scar tissue or fibrosis in the muscle biopsy. And because there's not a lot of inflammation, anti-inflammatories or immunosuppressives don't seem to help the muscle disease in non-inflammatory myopathy as much as in inflammatory disease. And then the fourth type of muscle disease that I mentioned that you should think about in scleroderma patients is this immune-mediated necrotizing myopathy. So it's an autoimmune muscle disease. So your body's attacking yourself, attacking your own muscles, associated with autoantibodies. And the majority of these patients have had prior use of statins, those medications that are taken for cholesterol. And it's also been reported in patients with scleroderma, whether or not they've been on the statins or not. So it's thought to be an autoimmune muscle disease. And in patients with connective tissue diseases, it can be associated with antibodies called the anti-signal recognition particle, or anti-SRP antibodies. And in patients who have taken statins in the past, as well as in patients who haven't, but that's less common, it's associated with these antibodies called the anti-3-hydroxy-3-methylglutarol coenzyme A reductase antibodies, or HMG-CR antibodies. So the reason these antibodies are thought to be so interesting is because the HMG-CR is actually the target of statins. So it's thought that you take these statins and they upregulate this response that your body makes these antibodies to target the statins, and they cross-react with your body. So they end up attacking your own muscle cells as well. So this form of immune-mediated necrotizing myopathy has been described in patients with scleroderma. It's rare, but it's a form of muscle disease that is now more recognized in patients with scleroderma. So the defining characteristics of this type of necrotizing myopathy is that there's necrosis or death of muscle fibers. You see these degenerated muscle fibers compared to these larger, well-rounded ones. Degeneration, again, they're starting to shrivel away these muscle fibers, as well as regeneration of muscle fibers, because new muscle fibers are trying to form to replace the old ones. And there's really not much inflammation here, and I'll show you slides of other types of myositis where you can actually see a lot of inflammation in the muscle biopsies. So in patients with scleroderma who develop this form of muscle disease, they have a rapidly progressive course. So they develop severe muscle weakness. And they also could have an underlying associated cancer. So this type of myositis or myopathy, you should do cancer screening for patients with scleroderma. The other thing is, even though they don't have a lot of inflammation on their muscle biopsies, they seem to do pretty well with immunosuppressive treatment. And it's thought that because maybe these antibodies are what is actually causing the muscle damage. So now I've gone through the different types of muscle disease that you can see in scleroderma patients. And now you're probably wondering, well, how frequent is muscle disease in scleroderma? Is this something that I need to worry about? So unfortunately, there's been a wide range of frequency of muscle disease described in scleroderma patients. And it basically depends on the way you define muscle disease. So anywhere from 7 to 81% of scleroderma patients have been described to have muscle disease. So this could be defined as muscle weakness, it could be defined as elevation of muscle enzymes in your bloodstream, or inflammation on muscle biopsy. I think in general, when you look for evidence of muscle inflammation, about 10 to 15% of patients have actual muscle inflammation, and probably another 15 to 20% have non-inflammatory muscle disease related to scleroderma. In one study looking at the incidence of muscle disease in scleroderma patients, so basically they looked at 137 patients and followed them over time. At baseline, none of them had muscle disease. And over 4 years of follow-up, 9 of them, or about 6.5% of them, developed muscle disease over time. So what puts you at higher risk for developing muscle disease in scleroderma? So I just gave this talk on PAH, and one of the risk factors for PAH is having older age at onset of your scleroderma. Well, for muscle disease, it's actually younger age for your scleroderma onset, so 20s, 30s, 40s, let's say 50s is young too. And male gender also seems to be associated with a higher risk for developing muscle disease. Having widespread or diffuse skin tightening is associated with a higher risk for developing muscle disease, and patients with diffuse disease are 3 to 5 times more likely than those with limited skin involvement to develop muscle disease. Interestingly, again, the anti-centromere antibody that I just talked about in the PAH lecture as increasing your risk for PAH, actually the absence of the anti-centromere antibody increases your risk for muscle disease. So which would you rather have? I'm not sure. We'll talk more about muscle disease, and maybe I'll persuade you you'd probably rather have muscle disease. Some of the other clinical associations with muscle disease and scleroderma include widespread skin pigmentation. I'm not sure why, but it may have to do with the association with having diffuse skin involvement and having a lot of pigment change associated with that. Contractures of the fingers. Again, contractures are often associated with diffuse skin involvement. Lung disease, pulmonary fibrosis. There was one study that found that you were 3 times more likely to have reduced forced vital capacity on your pulmonary function test if myositis was present. So there's some association between myositis and lung disease, but whether or not that's related to muscle involvement of the diaphragm or truly pulmonary fibrosis, I think is unclear. What definitely multiple studies have shown is that there's a connection between having muscle disease and heart disease. So 64% of patients who have muscle inflammation have heart involvement. And you're 2.5 times more likely to have heart disease if you have muscle disease than if you don't have muscle disease. So what defines heart disease? If you have arrhythmias, congestive heart failure, reduced heart function. So again, you're more likely to have heart disease if you have myositis present, and likewise, you're more likely to have myositis if you have heart disease. So the two of them are associated. So as I mentioned in my prior lecture, autoantibodies are really helpful in determining what patients are at risk for developing in terms of internal organ involvement. Listed here are several autoantibodies that are associated with developing myositis in all the connective tissue diseases, not just scleroderma. So I'll talk about the ones that are clinically available, which include the PMSCL antibody, the anti-Q, anti-U1RNP, and anti-U3RNP. And the anti-RVL12 is a more novel autoantibody that really isn't clinically available. The Roe and Law antibodies, I think, are not really specifically associated with myositis, but basically can be seen in any of the connective tissue diseases. So regarding the anti-PMSCL antibody, basically PMSCL is kind of short form for polymyositis scleroderma. So that helps you remember that these are patients with features of polymyositis or muscle inflammation and scleroderma. These antibodies are present in anywhere from 2 to 12% of all scleroderma patients. but about a quarter of patients with the polymyositis scleroderma overlap will have these antibodies. Other clinical associations with these antibodies include, again, younger age at symptom onset, associated more with Caucasian ethnicity. And although muscle disease is more common in diffuse patients in general, this antibody is associated with muscle disease in limited skin involvement. In addition, some other clinical features associated with this antibody include calcinosis, or calcin under the skin, inflammatory arthritis, and then less commonly are Raynaud's phenomenon, GI disease, and pulmonary arterial hypertension. So it seems that these patients have more inflammation in their muscles and joints and less of kind of the vascular problems that patients with PAH and bad Raynaud's get. So this antibody, the anti-PMSCL antibody associated with muscle disease, limited skin involvement, actually is associated with better survival. So you can see here, this is PMSCL negative patients, and this is PMSCL positive patients. So at 10 years, there's a much better survival in patients who have this antibody. It's a blood test, yes, and it is clinically available. The other name for it is PM1. So anti-Q antibodies are another autoantibody associated with muscle disease in scleroderma patients, present in about 5% of scleroderma patients, so not quite as frequent as the PMSCL antibody. Also can be seen in patients with lupus, especially those who have muscle disease. And again, clinical associations with this antibody, again, joint pain is common, but unlike the PMSCL, Raynaud's phenomenon is common in these patients. And of course, inflammatory myositis associated, and they tend to have a good response to corticosteroids. So a lot of inflammation seen on the muscle biopsies and good response to therapy. Also, the anti-Q antibodies are associated with interstitial lung disease as well. Unfortunately, the interstitial lung disease doesn't always correlate with the muscle disease in terms of response to therapy. So it's interesting that the muscle disease can respond well to steroids, but the interstitial lung disease may not in these patients with the anti-Q antibody. The anti-U1RNP, or ribonuclear protein antibody, you probably have heard about it because it's associated with mixed connective tissue disease, so patients who have a lot of overlap features, maybe some rheumatoid arthritis, lupus, and scleroderma features, but often associated with muscle inflammation. And about 5% of scleroderma patients have this antibody. So again, younger age at disease onset. And again, this group of patients has more limited skin involvement, despite the fact that they have muscle inflammation. Again, arthritis is an associated factor. And in these patients, unlike the PMSCL patients, they have severe GI disease, and they have pulmonary hypertension. So it seems that in the mixed connective tissue disease, the high U1RNP antibody patients, there's a lot of inflammation, just like the PMSCL patients, but there's also a lot of vascular damage. So this antibody also increases your risk for PAH.
So when you have GI disease, will it remain? In other words, if you have GI disease, will it remain, or can, over time, will it increase?
So most typically, and Tracy Freck will be giving a great talk on GI disease and scleroderma today, but most frequently the GI disease is fairly progressive over time. So the anti-U3RNP, also called the anti-Fibrillarin antibody, again detected in a small portion of patients with scleroderma, about 4%. And these patients tend to be more likely male. These are the ones who have diffuse skin involvement and are more likely to develop muscle inflammation. Again, younger age at onset of their disease. African American race is also more associated with this antibody. And in addition to muscle inflammation, these patients are at risk for lung disease, and not only pulmonary arterial hypertension, but also pulmonary fibrosis. So this antibody we can't clinically test for at all centers, but it's associated with a nucleolar pattern on the ANA. And again, if you see an African American patient with a nucleolar ANA, you can probably bet that they have this antibody, and you should look for muscle inflammation as well as lung disease. The anti-RUV-BL1-2 antibodies, these are more for research purposes right now. They're really present in only a few percentage of patients with scleroderma, but seems to be very much associated with muscle disease and heart disease, as well as diffuse skin involvement. And unlike the other autoantibodies associated with muscle disease, these patients seem to have older age at disease onset than with PMSCL, CU, and RNP antibodies. So I've now reviewed kind of the risk factors associated with developing muscle disease and scleroderma. So what are the symptoms that you should be looking out for to assess whether or not you have muscle disease? Again, symptoms in scleroderma can be so nonspecific, but one of the primary symptoms of muscle inflammation or muscle disease is weakness. And in particular, in patients with polymyositis and dermatomyositis, where we know there's inflammation, it's usually symmetric proximal muscle weakness. So it's both sides equally, and it's usually your proximal muscles, which are closer to the core of your body. So your shoulders, your hip girdle muscles. So it's difficult to get up out of a chair, difficult to climb stairs, difficult taking things off the shelf, blow drying your hair or brushing your hair. And then the smaller muscles of your hands, what we call the distal muscles, those usually get involved later. So then you start having trouble with grip strength, opening jars, opening bottles. Those muscles usually get involved later in disease. Other muscles that you don't think about so frequently that can be inflamed and related to myositis are your throat muscles. So difficulty swallowing is one of the major muscles that can often get involved with inflammatory myositis. Now, it can get confusing in patients with scleroderma because you can have difficulty swallowing related to a stricture from bad reflux for many years, or from dysmotility because your GI, your gastrointestinal system isn't moving food through very easily. So there are lots of reasons you can have difficulty swallowing, but inflammation in the muscles is one of them. Having a hoarse or scratchy voice, so you can get laryngeal muscle involvement from inflammation, and that can be a sign of muscle inflammation. Difficulty breathing. So I mentioned that a lot of these antibodies are associated with interstitial lung disease as well as muscle inflammation. So you may have difficulty breathing related to interstitial lung disease and muscle inflammation, or if you have really severe muscle inflammation, it can actually affect the muscles of your diaphragm and lead to weakness there and difficulty breathing for that reason. Myalgias or muscle pain. Now that's such a common problem in patients with scleroderma and all connective tissue diseases, but could be a symptom of muscle disease. And lastly, fatigue. One of the most nonspecific symptoms, can be related to multiple things, but could be a sign of muscle disease. So there are possible other associated symptoms. As you saw, many of those antibodies are associated with muscle inflammation as well as joint inflammation. So joint pain or swelling is something you should assess for. You should assess for how bad the Raynaud's is and whether or not they have digital ulcers. So the PMSCL antibody not so associated with Raynaud's and digital ulcers, but the U1RNP antibody is. Other features that you can develop: fevers, weight loss. There may be an associated cancer in patients with dermatomyositis and polymyositis. They're at increased risk for developing cancers. If there's heart involvement, chest pain, palpitations, feeling your heart racing or feeling your heart skip a beat. And then if you have an overlap with dermatomyositis, you can develop classic skin rashes. So I won't show you pictures of all the various dermatomyositis rashes, but here are a few of the hallmark rashes that you can get with dermatomyositis and with dermatomyositis scleroderma overlaps. So this is the heliotrope rash, where you can see there's redness and swelling over the eyelids. This is the Gautrin's papules, where you can get these little raised little bumps over your joints. This is periungual telangiectasias, or little telangiectasias, dilated capillary loops around your nail folds. And then this is what we call the V sign. You see that there's a lot of redness around a sun-exposed area of the chest in a patient with dermatomyositis. So if you see any classic rash, and you also have muscle weakness and other signs of muscle inflammation, you may have a dermatomyositis overlap. So once we've gotten a history of weakness from our patient, how do we evaluate whether or not there's truly muscle disease going on? So we test their muscle strength. We do a test called the Manual Muscle Test 8, and I'll go through that on the next slide, but basically test how strong the patient is. And it's good to test it over time to see if patients are getting stronger or weaker. Muscle tenderness is fairly nonspecific. If a patient is tender in one particular muscle, then you might worry more about an infectious problem than an inflammatory or non-inflammatory problem related to the scleroderma. I mentioned about looking for skin rashes, also looking for sores or ulcers on the fingers, looking in the mouth for sores as well, and doing a joint exam, looking for arthritis, and of course listening to the heart and lungs, looking for associated heart or lung disease with muscle disease. So this is the Manual Muscle Test 8, and we basically test 8 different muscle groups: the neck flexors, the deltoids or shoulder muscles, the biceps, the gluteus muscles, the quadriceps, the wrists, and the ankles. And so, you know, if you test more muscles, you can get a Manual Muscle Test 26, but this test basically takes a lot longer, and the MMT8 has been shown to be just as sensitive of a test. So that's the test that you really should be having your physician do at every visit. So typically the rheumatologist does this, yeah. The higher the number, no, the stronger you are. So each muscle group is scored on a scale from 0 to 10. So 80 is a perfect score. So as I mentioned, there are lots of reasons to develop muscle disease that aren't related to scleroderma. So you definitely want to make sure you're tested for those problems first, looking at the electrolytes, looking at your thyroid function tests, looking at the urinalysis, making sure there's no blood that might be indicative of like a crush injury or rhabdomyolysis, looking at the autoantibodies, and then muscle enzymes. These are tests that you can test in the blood of patients. Basically, they're released whenever there's muscle inflammation. They're released into the bloodstream. So there are multiple different muscle enzymes that we test, and elevation of any one of them can reflect muscle inflammation. So you may have heard of the test called the creatine phosphokinase, or the CPK. And this is probably the most sensitive for muscle inflammation, but it's definitely not the only test that your doctor should be doing when they're looking for muscle inflammation. So the aldolase test is actually a really important muscle enzyme that should be evaluated. Liver tests, believe it or not, can represent muscle inflammation. So the AST and ALT could be markers of muscle inflammation. If there's nothing going on in your liver, you're weak, and these are elevated, it's probably related to muscle inflammation. Lactate dehydrogenase is it's a test that often gets elevated when you have high cell turnover. So it's thought that when muscle cells are dying, they often will release this substance into the blood. And then troponin, you may have heard of this. It's actually a measure often that they do when they're looking for a heart attack, if a patient comes in with chest pain. But if you have heart muscle involvement, the troponin can be elevated. So I mentioned the aldolase is a very important muscle enzyme that really should be tested in all scleroderma patients to assess for muscle disease. So this recent study from 2012 showed that the elevated aldolase was actually the most predictive of the muscle enzymes for the future development of muscle inflammation. And now the normal cutoff for aldolase is 7.2. So even a mildly elevated aldolase, once it's greater than 9 at baseline visit, it predicted the onset of muscle inflammation within 3 years, increasing your risk by tenfold. So these are the patients who had normal aldolase, and these are the patients who had aldolase greater than 9, and the likelihood of developing muscle inflammation within 3 years was much increased. So I think it's a very important test. Now, it's not 100% specific for muscle inflammation. If you have something going on in your liver, if you have liver inflammation, the aldolase can go up as well. So important to realize that. And your liver should be examined before assuming that it's muscle inflammation. So once we've done all these blood tests, the next step we do is an electromyography, or EMG. And this is not the most comfortable test for patients. Basically, you have these probes, otherwise needles could be another name for it, that are inserted to stimulate the muscles. We also do nerve conduction studies at the same time, so stimulate your nerves and your muscles to look for any signs of muscle inflammation. And this is a list of what we as physicians have to memorize as the classic triad associated with muscle inflammation. And I still to this day cannot memorize all these. But about 40% of patients with muscle inflammation will have this classic triad. So, you know, the EMG is not perfect. It misses about 60% of patients who have muscle inflammation. But, you know, this can give you a general sense, and it's a fairly easy test to undergo. And you can do a nerve conduction study at the same time to exclude nerve problems of weakness, which is often happening at the same time. The other helpful aspect of the EMG is that if you find a particular muscle that shows some of these abnormalities, you can do a muscle biopsy, and that will increase the likelihood that you'll see muscle inflammation on the biopsy. It's important to realize, though, that you do the biopsy on the opposite side of where the EMG was done. And the reason why is because the EMG can interfere a little bit with the muscle biopsy results. So the muscle enzymes, the EMG, they're very helpful. They can often capture probably 50–60% of patients who have muscle inflammation. But there's a group of patients who have normal muscle enzymes and a normal EMG, but they're weak and you can't figure out why. You've excluded all other causes, and then you do an MRI and you see that they do actually have muscle inflammation. So MRI is being used more and more. It's a very expensive test, which is why if you see inflammation on muscle enzymes and or EMG, you may not go on to an MRI. But basically, you look for bright signals on a type of image called a T2 weighted image of your MRI. And oftentimes, we have trouble getting these tests approved by insurance. So we choose the area that is weakest on exam and just try and MRI that area to assess for muscle inflammation. But there was a study done just of 18 patients doing a whole body assessment using MRI, and found that the muscle involvement can be very widespread and also can be somewhat patchy. So you might not catch it in that one area you're able to get the MRI of. The good thing to know is that about 44% of patients who have this whole body assessment have lower legs involved, and most severely. So that might be an area that you should go for. Just say if a patient has weakness everywhere, where do you want to go for? Probably would choose the lower legs. And the muscle weakness corresponds with two findings on the MRIs. Muscle edema, which is thought to be fluid in the muscles and representative of inflammation, and then fasciitis. So fascia is the tissue that surrounds the muscle, and it's thought that that area can get inflamed as well and lead to muscle weakness. So what does it look like when you look at the MRI? On this side, you can see the arrows pointing to these bright signals within the muscle. This is considered muscle edema. And then here you can see the arrowheads pointing to bright signals in the fascia, and that is consistent with inflammation or fasciitis.
How much is this related to pain?
So that's a great question. You know, pain can be caused by multiple factors, but muscle pain is probably present in at least a third to a half of patients with muscle inflammation. So, You definitely want to rule out other causes of muscle pain, but certainly muscle inflammation can be one of the causes of muscle pain. So finally, the gold standard for diagnosing muscle disease is a muscle biopsy. And these are actually outpatient procedures that you basically have about a 2-inch incision, and there are actually even less invasive muscle biopsies that are being performed. And so getting a good piece of tissue is really important, though, because as I mentioned, the muscle inflammation can be patchy, so you could get a negative biopsy even with the presence of inflammation. The other thing is we like to do the muscle biopsy before patients have started treatment, because certainly the treatment can decrease the amount of inflammation, and then you may be missing the true diagnosis. So in scleroderma, there are different features you can see on the muscle biopsy. As I mentioned, inflammation is one of them, dead tissue or necrosis, scar tissue or fibrosis. Atrophy is basically the deterioration of the muscle fibers. And then microangiopathy is blood vessel damage that you can also see in the muscles. Yeah.
Doing a biopsy, compare, most scleroderma patients don't do any arbitrary type surgeries because scarring effect.
Wound healing, yeah. So it's interesting. There are very few studies looking at muscle biopsies in scleroderma patients, and probably the reason why is because they know they have underlying scleroderma, and they have elevated muscle enzymes and muscle weakness. So what is the muscle biopsy going to tell you? I'm going to argue here today that there actually might be utility in getting muscle biopsies on patients with scleroderma. Certainly in patients with polymyositis, it's almost a requirement because polymyositis patients, you don't have features of underlying connective tissue disease, so it's unclear what's really going on. So it's absolutely necessary for those patients. Dermatomyositis patients, we also don't always do biopsies in the muscle because if they have that classic skin rash, they're weak, and they have elevation of muscle enzymes, you don't really need to verify the diagnosis with a muscle biopsy. But I'll give you a little bit of data today telling us that maybe a muscle biopsy is helpful in scleroderma. So there are various muscle biopsy categories that patients with scleroderma can fit into. So it turns out, I mentioned maybe like 10, 15%, so like 12% have forms that are consistent with inflammation, like polymyositis or dermatomyositis. But more commonly, they have non-specific myositis, which means they have some inflammation, some fibrosis, some dead scar tissue. And then about 20% have this necrotizing myopathy, where it's primarily the dead tissue. And a small percentage of patients will have scar tissue only. A small percentage will actually have nerve damage and no problems with the muscle themselves. So now I'm going to show you some pictures of what the muscle biopsies look like in these various categories. So actually, even though people lump polymyositis and dermatomyositis patients together all the time, they're different not only in the fact that dermatomyositis patients have the skin rash, but they're actually different on muscle biopsy as well. So patients with polymyositis get these inflammatory T cells that actually surround and invade the muscle fibers. And the blood vessels themselves are not affected at all. Whereas in dermatomyositis, you see this very profound inflammatory infiltrate, and this is surrounding a blood vessel. So it's called perivascular inflammation, and that is one of the classic features in patients with dermatomyositis. That's why they seem to have more vascular problems, like they also develop Raynaud's and ulcers frequently. The other classic feature in dermatomyositis is atrophy or degeneration of the muscle fibers around the muscle fascicle, and that's called perifascicular atrophy. So if you find either one of these, even if there's no skin rash, that person more likely has a dermatomyositis overlap compared to polymyositis where the inflammation is more surrounding the muscle fibers. We already talked about the necrotizing myopathy. These muscle biopsies are characterized by having very little inflammation, so there's not a lot of inflammation around these muscle fibers, but a lot of dead and degenerating muscle fibers. And then some other features that are seen predominantly in scleroderma muscle disease. The scar tissue here, all these areas are highlighting scar tissue related to muscle disease and scleroderma. And the arrows here point to degenerating or atrophying muscle fibers, which is also seen in patients with scleroderma who have more of the nerve damage rather than actual muscle damage. So again, I'm trying to argue here that the muscle biopsy can give us a lot of information here. So we know that if you see a lot of inflammation, then the CK levels often correlate with the presence of inflammation on the muscle biopsy in scleroderma patients. So there was a high correlation between having inflammation present on the biopsy and having elevated CKs. So that's a good thing because then you know, okay, I can follow the CK to tell me whether or not we're doing well in terms of the muscle inflammation. Interestingly, it also correlated with the presence of necrosis. So again, high CK levels were seen when there's a lot of necrosis. Now, the other correlation with the CK test is that the non-specific myositis, where you have a little inflammation, a little fibrosis, a little dead tissue, that was the type of pathology most frequently seen when you had high CK levels present. In contrast, the nerve damage was associated with low CK levels. So, you know, it is important to be able to say, well, all right, I can't follow the CK levels in this patient because they have nerve damage. So how am I really going to be able to assess how they're doing? That's a more difficult patient to treat and follow. This is from the same study and looking at the disease duration of scleroderma at the time of onset of the muscle disease, essentially. This is when the muscle biopsy was performed. And so patients who had the polymyositis form of muscle inflammation had a shorter disease duration between the onset of their scleroderma and the onset of muscle disease. Whereas if they had a lot of nerve damage, they usually had scleroderma for a long time before the muscle disease came upon them. In terms of association with antibodies, the anti-PMSCL antibody and the anti-SCL antibody were associated with having a shorter disease duration between when your scleroderma started and when you developed muscle disease. So about 1.5 years for PMSCL and 2.5 years for the anti-SCL70 antibody. Okay, so finally I'm going to talk about the treatment of muscle disease in scleroderma. So, of course, we have medical therapies, but one of the major aspects of treatment is physical therapy. This is so important. You know, pretty much every scleroderma patient who comes in my door, I recommend physical therapy. And it's typically hand therapy for skin tightness and prevention of contractures, but in terms of muscle disease, really important to prevent atrophy and loss of muscle mass. So I'll go through a few studies regarding physical therapy. The oral immunosuppressants are drugs that we use for interstitial lung disease, arthritis, and very effective in treating muscle inflammation. And they can be used in combination as well. IVIG, or intravenous immunoglobulins, are a very effective form of treatment for muscle inflammation, and that could be in dermatomyositis, polymyositis, or in scleroderma-associated myositis. And then finally, I'll talk about some biologic therapies that are a little bit more experimental. So why is physical therapy so important? Well, there are multiple causes of muscle weakness in scleroderma patients. It's the muscle inflammation itself, obviously, that can lead to muscle breakdown and muscle weakness. Muscle pain can cause patients to not want to use their muscles and thus lead to physical inactivity and atrophy. then a lot of patients are actually on corticosteroids for the treatment of their muscle disease, which can actually lead to muscle atrophy if you have too much for too long. So previously, physical activity was actually discouraged for patients who had inflammatory myositis, and there was concern that you would aggravate the muscle inflammation if you did physical activity. But there have been studies, multiple studies, showing that muscular training is not only safe, but also effective in improving functional status in patients with muscle inflammation. And there were actually a couple of controlled studies where patients either had aerobic exercise, so not just muscular training, but actually aerobic exercise versus no exercise at all. And so the exercise included cycling and a step-up exercise program that really got your heart going to 60 to 70% your max heart rate. And there was improvement in oxygen uptake, disability, and also no worsening of muscle inflammation in those who underwent the exercise program. So we now recommend for patients with muscle inflammation, certainly physical therapy, but also having a stable level of activity, not pushing it and not doing a lot of heavy lifting, but certainly aerobic exercise and stretching and muscular training is acceptable and encouraged. So in terms of drugs to treat muscle inflammation, so we have multiple oral immunosuppressive drugs that you can either use alone or in combination to treat muscle inflammation. So corticosteroids are often the first line of treatment for muscle inflammation, particularly in polymyositis and dermatomyositis. Now, in scleroderma patients, you do have to realize that there's an increased risk for developing scleroderma renal crisis when you take corticosteroids, particularly in patients who have diffuse skin involvement, those who are early on in their scleroderma diagnosis, and those who have an antibody called the RNA polymerase III antibody. So you probably want to minimize or avoid steroids in those patients. There's also a lot of long-term side effects with steroids, including thinning your bones, osteoporosis, increasing risk for infection, hypertension, diabetes, glaucoma, cataracts. So it's not a great long-term medicine, but corticosteroids work quickly and can be very effective in treating muscle inflammation. So some of the other oral immunosuppressants that you might start at the same time as corticosteroids and then eventually taper off the steroids include methotrexate, mycophenolate mofetil or Cellcept, azathioprine. Those are probably the three most common medications we use for muscle inflammation. You do have to monitor the blood counts and the liver tests for all of these medications. Cyclosporin and tacrolimus are probably used less frequently, and they're associated with increased risk for hypertension and causing kidney problems, so we don't use them quite as frequently. And then cyclophosphamide. We kind of reserve this medication for patients with very severe muscle inflammation, severe muscle weakness, or those who have associated interstitial lung disease. And it's a very powerful medication that can be used for, 3 to 6 to 12-month period of time and then transitioned on to some other medication. It can be given IV or oral. Definitely associated with a high risk for toxicity, increased risk for infection, risk for bladder irritation, as well as an increased risk for bladder cancer. But very effective medication that can work fairly quickly for muscle inflammation. IVIG, a very effective medication for treating both the muscle and skin inflammation associated with polymyositis and dermatomyositis. And typically we use IVIG if patients have severe weakness, if they have difficulty swallowing that's related to muscle inflammation, or if there's any diaphragm weakness. They probably need respiratory support and IVIG as well as high-dose steroids immediately. So IVIG is given as an infusion. It's given at a dose of 2 grams per kilogram divided over 2 to 5 days, and it's given every 4 weeks or once a month. It works pretty quickly, and within 2 weeks, patients can often feel a little bit of improvement, but really it takes a good 3 to 4 months to get in your system and to reach maximum benefit. The one problem with IVIG is that sometimes it can lose effectiveness over time. You kind of tolerize to the medication, but that's only in some patients. It's also quite expensive, so that's the other downside of IVIG. There are also potential side effects with IVIG that you should be aware of. Certainly, infusion reactions are possible with any type of infusion. Headache is a really common problem with patients treated with IVIG. We pre-treat patients with a drug called periactin, and this has really helped to reduce post-IVIG headaches. But you should be aware that if they have persistent headache post-IVIG with neck stiffness, that aseptic meningitis is a reported side effect or complication of IVIG. Also, if you're at high risk for blood clots, you shouldn't get IVIG. So if you know you have antiphospholipid antibodies or you've had blood clots in the past, you should tell your doctor, and IVIG would not be given. Like with the other drugs, we do have to monitor blood counts, liver tests, and kidney function with with IVIG. And for patients with bad diffuse skin tightening who have trouble getting IV placement, there's now a subcutaneous version of immunoglobulins that may be able to be given instead of IVIG. So regarding biologic therapies, these are a little bit more experimental, but rituximab has actually quite a bit of evidence showing that it can be useful for treating muscle inflammation, at least in polymyositis and dermatomyositis patients. So this is actually the largest clinical trial done ever in patients with inflammatory myositis, including 200 patients who were failing other therapies. And it's given as a 1 gram infusion at day 0 and then 2 weeks later. And 83% of patients who received rituximab had an improvement in their muscle strength and other signs of muscle inflammation after treatment with rituximab. This drug could also be helpful for associated interstitial lung disease, so maybe a choice from the get-go if patients have interstitial lung disease and muscle inflammation. But again, there are potential side effects. Infusion reactions are possible with the rituximab, just like with IVIG, and infectious complications, particularly reactivation of various viruses, hepatitis B, hepatitis C, and the JC virus, which can lead to a very debilitating condition called progressive multifocal leukoencephalopathy. So, definitely rituximab can be very effective for muscle disease and interstitial lung disease, but there are risks for infections and infusion reactions. There is another biologic therapy that you may have heard about, abatacept, which is approved for rheumatoid arthritis, and trials are currently ongoing for scleroderma patients with this drug. So this drug was given to a small number of scleroderma patients, 7 patients with muscle disease. And at 18 months of follow-up, these patients had mild improvement in their muscle symptoms, as well as their muscle inflammation measured by the CK. So abatacept may be a potential future therapy for muscle disease, but we're currently studying it right now in scleroderma patients. So just a few more slides on the prognosis of scleroderma muscle disease. So the good thing is about 70% of patients treated for muscle inflammation will improve with treatment. And 40% of them will actually have a complete remission in terms of their muscle inflammation. So this is the reason I was getting at that a muscle biopsy might be helpful in determining whether or not a patient's going to improve and why it might be useful to get a muscle biopsy in scleroderma patients. So basically, the take-home message is if you have inflammation and necrosis on your muscle biopsy, you have a great chance of responding to therapy. If you have inflammation alone, you have a 45 times higher likelihood of responding to immunosuppression. Necrosis alone, you have a 16.5 times likelihood of responding. But the combination of the two really improves your chances of improving with immunosuppressive treatment. Whereas if you don't have inflammation or necrosis, only 13% of patients responded to immunosuppression. So, unfortunately though, even though the muscle disease itself often can respond to therapy, patients with muscle disease overall have a poorer survival than those without muscle disease. And why is that? It's probably because of the other problems that are associated with muscle disease, such as heart disease, interstitial lung disease, and pulmonary hypertension. So, unfortunately, the heart and muscle involvement in scleroderma don't respond the same to immunosuppressants. So, although the muscle inflammation gets better with steroids and immunosuppression, oftentimes the heart involvement does not improve. So 72% of scleroderma patients with muscle and heart involvement died over a 6-year follow-up period. So really, if you see a patient has muscle disease, assess for heart involvement, and you really want to try and maximize how strong their heart is. Sudden cardiac death, so arrhythmias, can be a major cause, and so assessing for arrhythmias and getting a pacemaker placed early on while the patient is still strong and doing well could help prevent complications. Okay, this is my last slide, summary slide. So scleroderma-associated muscle disease is common and can involve various features on the muscle biopsy, including inflammation, necrosis, fibrosis, and or atrophy of the muscle. Clinical symptoms include muscle weakness, difficulty swallowing, hoarse voice, difficulty breathing, muscle pain, and fatigue. And muscle disease is commonly associated with heart involvement, so your heart should be evaluated if muscle inflammation is found. And evaluation includes physical exam muscle strength testing, testing of blood tests including muscle enzymes, autoantibodies, thyroid tests, electrolytes. An EMG may be useful to detect muscle inflammation as well as an MRI. And then a muscle biopsy, as I mentioned, can be very helpful to assess for inflammation and necrosis, which can be helpful in determining if you'll respond to therapy. Physical therapy and a combination of immunosuppressants and or IVIG can be really helpful for treating muscle inflammation. And again, inflammation observed on the muscle biopsy is strongly predictive of a good response to treatment. So this is my thank you slide to the Scleroderma Foundation, my other funding source, the Scleroderma Research Foundation, and my collaborators at Stanford.